Good morning, everyone. Welcome to this third webinar. Understand that this is the third, but we have postponed the second one. So we'll be scheduling the second one for April. So stay tuned for the next information about that. So welcome to the webinar series of Sailing to Lisbon. This is a webinar series we're organizing, ramping up for the European Public Health Conference to take place in Lisbon this November. So keep updated with the website that has all the information. And I'll share just a brief video on Lisbon to somehow motivate you to come and stay a little bit longer, either before the conference or after the conference. So please enjoy the video. It will be a short 1-minute video. This was the first video. I'll show you that.
Close your eyes and listen. In Lisbon, the land awakens to life through its captivating sounds. Immerse yourself in the symphony of the sea, in our typical flavors, and in the joyful sound of a beer opening, a toast to Lisbon's welcoming spirit. Feel the rhythm of Lisbon's cobblestone streets, blending art and urban energy. Let the melodic strumming of Portuguese guitars tug at your heartstrings, transporting you to a place where Fado's evocative melodies embrace your soul. In our city, in your city, every sound tells a story that resounds with life. Lisbon, where everything sounds different.
So welcome back, and do come and enjoy the beautiful sights that we have in Lisbon, and also the food, the people. So it surely make your stay very welcome. So without further ado, I'll now give the floor to Inês. Inês Fronteira will be the moderator for this session. So Inês, you have the floor.
Thank you so much, Ricardo, and welcome everybody to the webinar dedicated to the theme of vaccines, the current and future challenges. In this webinar, we will address the theme of vaccines and the current and future challenge to the field. As you know, vaccines are among the most important developments in public health and are responsible for health gains in terms of vaccine-preventable diseases, with observed reduction in child and under 5 years of age mortality. More recently, vaccines have shown to be equally effective in reducing the severity or even in preventing some diseases in adults. Nevertheless, vaccination remains a controversial subject, as it was lately observed with the so-called COVID-19 vaccines. In this webinar, we hope to discuss the current challenge that might jeopardize lasting conquests to morbidity, mortality, and quality of life of people throughout the world resulting from vaccination. In order to do this, we have today with us two guest speakers. So Professor Christine Stabelben from Denmark and Professor Paolo Bonanni also from Italy. I will give first the floor to Professor Christine Stabelben. Professor Christine Stabelben is a medical doctor who has worked at the Bendine Health Project in Guinea-Bissau since 1993. She currently holds a position as professor in global health at the University of Southern Denmark, and she's also chair at the Danish Institute for Advanced Study. Her research focuses on health interventions and their effect on overall health in real life. She has observed that vaccines and vitamins affect overall health to a much larger extent than explained by their well-known specific effects. In addition to their specific effects, they have so-called non-specific effects, which may be at least as important as their specific effects. These effects are often sex differential, and they may affect each other, making the sequence and combination of health interventions more important than usually thought. Her main contribution has been to take the observations of non-specific effects of vaccines and vitamins forward to randomized controlled trials, being the PI for many trials testing the overall health effects of vitamin A supplementation, BCG vaccine, oral polio vaccine, and early measles vaccine. She has also bridged to immunology and explored the biological mechanisms underlying the non-specific effects of vitamin A supplementation and vaccines. She has taken the observations back to Denmark to test in randomized trials and observational studies whether non-specific effects of vaccines are important in high-income settings as well. Most recently, she has been testing whether the non-specific effects of BCG vaccines and oral polio vaccine can provide partial protection against COVID-19. Dr. Ben is also author of more than 300 scientific papers in peer-reviewed journals. Thank you very much for accepting our invitation to participate in this webinar series, and the floor is yours.
Thank you so much for the invitation to participate in the preparations for this exciting meeting. I will be sharing my screens, my slide here, I think. Can you all see my screen now?
Yes, we can. Thank you.
Thank you. So let me continue to talk about the things that Ines kindly introduced in her presentation of me, namely the overall and non-specific effects of vaccines. I always start with a disclaimer when I talk about vaccines. I find it important and useful to state up front that not only am I a medical doctor and with various titles, but I'm also the mother of 2 children who received all the vaccines in the Danish vaccination program. That is important to emphasize. But also that I spent more than 30 years now working in Guinea-Bissau studying the overall health effects of vaccines, which makes me a co-developer of this concept that I'll be talking about today, namely the concept of non-specific effects of vaccines. So I'm obviously biased in that regard. But apart from that, I don't have other conflicts of interest. The current paradigm for vaccines say that a vaccine is a biological preparation that improves immunity to a particular disease. You all know that. And you also know that the evaluation and monitoring is based on that interpretation because it's focusing on biomarkers or on the or just the actual vaccine disease. And then, of course, potential plausible adverse events occurring in the first weeks after vaccination. But unknown to most people, none of the currently used vaccines were tested for their effects on the overall immune system and its ability to handle other infections. There was this assumption that is still prevailing that the immune system wouldn't learn anything from meeting a vaccine that it could find useful in the context of other infections, other pathogens. So basically, the understanding of vaccines is that you can sit behind a desk in Lisbon or anywhere else in the world, and you can calculate the effect of a vaccine on overall health if you know its protective effect against the vaccine disease. And then you know, of course, also that you have to subtract these rare severe adverse events that could offset some of the benefits of the vaccine. But generally speaking, this is the theory that is applied when people sit and calculate how much a vaccine would impact overall health, overall mortality and morbidity. So for instance, if a measles vaccine was 90% efficacious and measles constituted 10% of all childhood death, as was the case when measles vaccine was introduced in low-income countries, then the assumptions would be that introducing a measles vaccine would reduce overall mortality by those 9-10%. But we have done research in Guinea-Bissau and West Africa which contradicts this assumption, and that is using our health and demographic surveillance system site that we have set up there that covers 200,000 people. We have created an infrastructure in a country where nobody normally has any address, and we have made regular home visits to assess the vital status, infections, and vaccines of children. And in addition, our assistants are present at the health centers and hospitals on a daily basis to monitor all vaccinations and hospitalizations. And this made it possible for us to do what nobody else had done before, namely to study what is the effect of vaccinations on overall mortality and morbidity, not just the mortality and morbidity from the vaccine disease, the disease that the vaccine was targeting. And out of that came a very surprising observation, namely that the effect on overall health could not at all be predicted based on the knowledge of the protective effect of the vaccine disease and the adverse events. So, for instance, for measles vaccine, we saw that when measles vaccine was introduced, mortality was reduced by 70%, 70%, much more than could be explained based on the protective effect of measles vaccine against the vaccine disease. So this made us propose that vaccines, in addition to their protective effect against the vaccine disease, also have non-specific effects on other diseases. And this is a hypothesis that has turned out to be confirmed in numerous studies, hundreds of studies. I'm going to show you just the example of the BCG vaccine against tuberculosis, which is given at birth to newborns in low-income countries, and where we were able to do randomized trials in low-weight neonates who, at the time when we did the trials, didn't get BCG at birth. So they would just get oral polio vaccine, and their BCG vaccine would be postponed until they had reached around 6 weeks of age. It was believed that they were too immature to receive BCG at birth. So on this slide, I'm showing you they would be the lower arm here in the randomized trials we did, because we randomized low birth weight children based on observational studies that suggested great benefits of getting BCG at birth, to receive oral polio vaccine at birth and the usual delayed BCG vaccine at 6 weeks, or to get BCG and OPV, oral polio vaccine, immediately at birth. And then we could compare in the neonatal period the overall mortality and morbidity, comparing otherwise comparable children where the only difference was whether they received BCG or not. And the results were very clear. These are 3 different trials in 3 different settings in Guinea-Bissau and 3 different periods, but showing marked reductions in neonatal mortality among children in black who got the BCG, who got randomized to the BCG vaccine at birth, versus those who were randomized to follow the normal procedures at that time and get BCG later. And in a combined analysis of this data, BCG reduced all-cause mortality by 38% in the neonatal period. And this was clearly not due to tuberculosis that doesn't kill children at birth, but we could show that this was mainly due to non-specific protection against septicemia and respiratory infections. So this is a clear proof that BCG did reduce mortality much more than anticipated from the specific protection against tuberculosis. And this finding has been confirmed in numerous studies, and WHO reviewed the evidence in 2014 and published in 2016 results that show that receipt of BCG reduced overall mortality by more than expected. And in a meta-analysis of the included studies, BCG was associated with almost a halving in child mortality, which clearly isn't explained from the prevention of tuberculosis. We also have an immunological mechanism now, innate immune training, where it has been shown that BCG can induce epigenetic changes in not least the monocytes that lead to increased cytokine production. And in this proof of principle study, we had Dutch medical students, adults volunteering to be part of an experiment where they got BCG or placebo. And then 4 weeks later, their immune system was challenged with a yellow fever vaccine, which normally creates viremia in the recipient, a brief viremia topping around day 5. And that was the case in those who hadn't received BCG vaccine. But in those who had received BCG vaccine, there was much less virus, as an indication that the monocytes that had been trained by BCG 4 weeks prior were able to respond more vigorously, not least with IL-1 beta, to the yellow fever vaccine and thereby reduce viremia. So a proof of principle that a bacterial vaccination affects how you respond to a virus 4 weeks later. We have also been able to show that BCG reduces systemic inflammation. So there are several mechanisms whereby BCG could have profound effects on the immune system and the risk of other infections and diseases. So if we should sum up the lessons learned from BCG, it has effects that cannot be explained by prevention of tuberculosis, with the reductions in all-cause mortality, the immunological studies that prove that there is changes in the immune response to other disease organisms, and as mentioned here. We are quite far in getting this acknowledged, and Nature declared the discovery of beneficial non-specific effects of vaccines a major milestone in 2020. So, and the same year we published this paper where we propose that it is really time to change the paradigm for vaccines. We cannot no longer assume that a vaccine doesn't affect other infections than the one that they're designed against. I want to turn to the implications of these non-specific effects of vaccines because they clearly have some conceptual implications and also practical implications. The conceptual implications are that they challenge the way we think of the immune system as only learning and only developing memory against that specific challenge that it meets. It also means that we can have a different view of how to protect against diseases because we don't necessarily need to vaccinate against each and every disease. We might focus rather on optimizing the fitness of the immune system so that it can combat a broad range of infections. It also emphasizes that vaccines cannot be seen as we shouldn't talk about vaccines in plural. I didn't touch much upon it, but all the different vaccines we have studied have different non-specific effects. Unfortunately, some of them also have negative non-specific effects. So it makes it pertinent to always talk about vaccines one by one and never make broad statements about vaccines are beneficial or safe or whatever. They are really as different drugs. And also, because the non-specific effects affect a broader immune system, it also is, of course, context dependent. You can't anticipate the same effect of a given vaccine depending on the state of the immune system that it's given into and the other health interventions that are given at the same time. So these conceptual implications also, of course, have some practical implications. And here I want to touch upon two, namely that I think we need to revise the childhood vaccination program to get not only optimal specific effects, but also optimal non-specific effects of vaccines. And we also need a revised framework for testing, approving, and regulating vaccines. And I'll just briefly show you here what I mean by that. I think, or the data points to the possibility that was presented here by Frank Schan in Clinical Infectious Diseases 2020, that if we have a vaccination program that emphasizes these live vaccines, which have the strongest beneficial non-specific effects, then it might actually reduce child mortality by 1 million deaths per year. So these non-specific effects are not trivial. They are major effects that can dramatically change the course of a child's life if they are implemented in the vaccination program. With regards to the system for testing, approving, and regulating vaccines, we published a paper last year where we come with our suggestions for how the ideal phase 3 trials should be conducted and the ideal post-marketing surveillance should be conducted, seen in the light that we have to assess the effect of any new vaccine on overall health, not just the vaccine disease. One of the most important factors here is that we should not only look at phase 3 trials at symptomatic infection, but on overall mortality and morbidity, and clearly also that this challenges the way we currently do post-marketing surveillance, which typically is only observational by comparing vaccinated and unvaccinated with all the pitfalls that entails, or before-after comparisons. But we should be doing randomized trials or at least step-wedged rollout with vaccines and monitor overall mortality and morbidity to be sure that we really understand the full effect of any new vaccine. So you can see that these findings pose some challenges to the current system for testing vaccines. We were, of course, curious when the new mRNA vaccines came, and the adenovirus vaccines, 2 new types of vaccines, whether they would have non-specific effects. And indeed, that might be the case, because when we did a reanalysis of all the randomized trials that led to their approval, just simply teasing out of the supplementary material the number of deaths, and for various reasons, in the mRNA vaccinated and the mRNA vaccine trials and the adenovirus vaccine trials, respectively, we saw that based on these phase 3 trials, comparing mRNA vaccine with placebo, there was no effect on overall mortality in the trials, there was an estimate of 1.03 with broad confidence interval that indicates that the vaccines could both be very beneficial in terms of overall mortality, but also harmful. But if we looked at the adenovirus vaccine trials, comparing adenovirus vaccine with placebo, then the adenovirus vaccines were associated with a 63% reduction in all-cause mortality, the effect estimate being 0.37, as you see here on the figure. But with a confidence interval that really emphasizes that the effects under all circumstances would be highly beneficial. And you can see the p-value here of 0.015, indicating that the effects of these two vaccine types on overall mortality was highly significantly different, suggesting that maybe the adenovirus vaccines, which are live vectored vaccines, may hold some beneficial non-specific effects. So if you look at this data, it might be that we actually stopped the wrong vaccine for the wrong reasons, because looking at overall mortality, which is after all what counts, there were strong differences between the two vaccine types. So this is just to say this work was not done when the vaccines were being tested. This is data that we have teased out of the trials, but this is work that I think should be done before any vaccine is implemented. It should be studied whether it affects overall mortality to the extent that one wishes to achieve with the vaccine. So I want to sum up here what we learned from studying the overall health effects of vaccines, namely that vaccines may have non-specific effects. They may also be sex differential. I didn't touch upon that, but that you can read in the review paper I alluded to. This is currently not taken into account when testing vaccines, and I fear that this has the potential to create breaches in vaccine confidence. And the fact is that we may actually be doing harm with some vaccines despite the fact that they protect against the vaccine disease. So we really need to, in the future, our future challenge that we are addressing today is to assess vaccines for their effect on overall health in both sexes. With that, I want to thank you for inviting me once again, and of course, thank all you, the people who participated in the studies that I've run briefly through here, and not least the mothers and their children of Guinea-Bissau who continue to trust us. They bring their children for vaccinations, and they also trust that the system will give them the optimal vaccination program to make their children grow up and survive. And we really need to continue to make effort to make sure that is always the case. Thank you.
Thank you so much, Christine, for your brilliant presentation. I will now give the floor to Professor Paolo Bonanni, who is a full professor of hygiene in the Faculty of Medicine and the director of the Specialization School for Medical Doctors in Hygiene and Preventive Medicine at the University of Florence, Italy. He was graduated in medicine and surgery in 1985 and was awarded 2 specializations in hygiene and preventive medicine at the University of Genoa in Italy. And from 1992 to 2000, he was associate professor before becoming a full professor in 2000. His scientific activity has covered the epidemiology and prevention of infectious diseases, particularly viral hepatitis, diphtheria, tetanus, pertussis, influenza, measles, rubella, varicella, and also most recently bacterial invasive diseases and human papillomavirus, including clinical trials and economic valuation of vaccination strategies. Professor Bonanni has been a member of the National Vaccination Commission of the Italian Ministry of Health, and he acts as an expert consultant for the European Centre for Disease and Prevention and Control, based in Stockholm, Sweden. He's a member of the European Technical Group of Experts on Immunization at WHO Europe, Copenhagen, Denmark, and he's standing advisor of the Viral Hepatitis Prevention Board, an international independent committee of experts in viral hepatitis prevention, and he has received several grants from the Italian Ministry of University on projects regarding vaccine preventable infections and was research unit leader in 4 EU-funded projects on vaccination. Currently, he is the head of the Adult Immunization Board. Thank you so much, Dr. Paolo, for accepting our invitation to participate in this webinar, and the floor is yours. You are muted.
Thanks a lot, Ines, for this kind invitation and for this very wide explanation of what I've done. So, I'm not the head of the adult immunization board. I'm co-chairing it together with Pierre Van Damme, my old friend Pierre Van Damme. I would like to first to thank Christine for this very interesting presentation. It was I learned a lot. My presentation is a little bit different as to the way of dealing. It's probably less scientific, but more on the policy, public health policy. For the implementation of adult vaccination. And I hope you can see my screen. So let me first cite Dr. William Schaffner, who in 2004, so exactly 20 years ago, stated that where we are with adult immunization is where we were 25 years ago with children immunization. It's like a drip coming out of the faucet. For children, it's turned on full force. So this meant that when we speak of vaccination, traditionally we speak of infant or childhood vaccination, but we need as well vaccines for the adult and the elderly. And I would say that this is a sentence of 20 years ago, but I would say that it's still true today after 20 years. So we have a lot of difficulties and challenges in implementing adult immunization in its full force as we need. I would like to start with some considerations, saying first that there is a discriminating factor between childhood and adulthood vaccination, which lies in the different public health approach of these two way of giving vaccines. And the reason is that the rationale for adult vaccination is not a one-size-fits-all. When we think of a childhood or infant immunization programs, we think of something which is given to large masses of children. We give the same vaccine to a lot of people. But on the other hand, when we speak of adult immunization, we target specific groups which are based, first of all, on age, but also on the prevalent diseases according to age. So, for instance, influenza, pneumococcal disease, herpes zoster are specific vaccines that are particularly useful for the elderly population. There are also other considerations like the age-independent comorbid conditions like immune deficiencies. And there are also other special conditions which are not diseases like pregnancy or living in residences for the elderly. But also we have to focus and we have to find the right vaccines for by type of risk linked to specific professional activities. So for instance, being an healthcare worker puts at a specific risk of some diseases, or to tourism and work needs, and so we are speaking of travels abroad. So you see that it's a little bit complicated picture, and we need to find solutions for all this. And for the implementation of adult immunization, we need to focus on four specific aspects. The first one is identifying in a correct way the target population. Who are our targets? So we should define well the denominator of those who we want to access and we want to offer vaccination. Then the second point is delivery. What is the health infrastructure of a certain country? What is the immunization platform that is used in that country? Is it easy to access this platform or this health system infrastructure? There might be important barriers in the delivery of vaccines, which may be available for the childhood vaccination, but not as much available for the adults and for the elderly. Then the other point is monitoring. We need to perform a very good surveillance for the disease burden. But another point which is frequently lacking in many countries is a vaccine registry for coverage. In some countries, we have registries for childhood vaccination, but adult immunization is not registered. And so we cannot understand well where we are in the development and in the implementation of a vaccination program for the adults. And again, the last point is what we hope for the future, demand. So we need to create awareness on old and new vaccines, awareness on the need of vaccines, and we would like to be one day at the point where we are not offering vaccines to the adult population and to the elderly, but they should be the ones who ask us to be protected using vaccines, because in the end we need just to create demand for adult immunization. And the delivery strategies may vary by target population. We need active vaccination offer to the target population to be successful. Vaccination of hospitalized patients, for instance, with high-risk condition, could be performed inside the hospital in dedicated services or at discharge, with an integration which needs to be built between hospital and territorial services. Vaccination of those living in residences for the elderly. We need to involve more, if not already in place, the GPs in the selection of candidates and in the administration of vaccines. We need to administer vaccines using simultaneous opportunities. For instance, we could offer vaccination during periodical screenings, like we do in some countries, offering, for instance, HPV vaccination on the day of the first screening, this first screening test for HPV DNA or PAP test. And also we need to involve more the specialists in ambulatories and hospital, and we need to create awareness on the importance of of considering vaccines as a part of the therapeutic plan for all high-risk subjects. And of course, we just need to create a functioning repository for vaccines in the adults. So registries of at-risk subjects to actively offer influenza, pneumococcal, and aspergillus zoster vaccination are crucial, and also other vaccines according to the risk. Of course, we can have some issues in some countries, especially I take the example of Italy, where privacy laws prevent you from advising people according to their risk condition on the availability of vaccine, which is really a big problem. So coverage in the adults is a hard to reach objective and also an easy to lose achievement. When there is some allegation that some vaccine could have made some damage, which is unproven and probably false, sometimes we see a dramatic drop in coverage that is very hard to be recovered, and it takes a year to go back to the coverage you had before the communication crisis. Let's say, and now I come to the main focus of my presentation, what is the Adult Immunization Board? We need to develop partnership, we need to create synergies, we need to generate demand, as I said, and use programs that prove to be successful. So from this, we had the idea of creating an Adult Immunization Board, because we have a vaccine recommendation that may change as we age, but not the need for protection with vaccines. So we need to use current and future adult vaccines, and we have a problem, as I said, of low coverage with these vaccines. The world population ages. We need strategies that support healthy aging by general prevention, healthy living, good practices, but also vaccines. We need to establish immunization program platforms for vaccine delivery for adults to decrease barriers to access. We need to equip immunizer citizens with the necessary tools to increase confidence in adult vaccines and clarify their importance. We need to increase vaccination record keeping in the adult population, investigate cost effectiveness and reimbursement of adult vaccines. So all this finds a very fragmented and complex landscape, because no single expertise can give a reply to all these needs. We need a multidisciplinary and holistic approach, and we wanted to create a collaborative learning platform, which is the Adult Immunization Board. What is the Adult Immunization Board? it's an idea that became reality in the last 2 years. Several organizations, including universities, governments, international public health organizations, and vaccine manufacturers, are currently considering how adult immunization can be further improved to increase health impact and promote a lifelong approach to vaccination. There was no independent discussion platform of experts focusing on this at the EU level. And therefore, in 2022, a group of experts in the field of adult immunization established the Adult Immunization Board, taking the experience from the Viral Hepatitis Prevention Board that was cited in my background. It's a multidisciplinary group of experts that is living now since 1992. So we have more than 35 years of life, and we had a lot of positive impact of this Viral Hepatitis Prevention Board. And another board was created in 2016, which is the HPV Prevention and Control Board. Both of them have their secretariat at the University of Antwerp. But in this case, for the Adult Immunization Board, we decided to join forces. This is a joint enterprise of the University of Antwerp and of my university, the University of Florence. We have a project coordinator, Jade Patin, from the University of Antwerp. We have 2 secretariats that organize the meetings from the scientific and from the logistical point of view. And you can see here the people involved in this enterprise. But we have a long list, 24 today, advisors, which act in their personal capacities, not representing directly their organizations, but they give their time for free. I wanted to underline that the Adult Immunization Board receives an unrestricted grant from Vaccines Europe just to organize the meeting, so to cover the expenses, but none of these experts receives any fee. We give our time for free to discuss on adult immunization. You can see here that we have people from institutions like WHO, organization of patients, experts from university, public health institutes, and also from the civil society. So, we have different expertise represented here: geriatricians, public health, immunologists, travel medicine, and so on, but also representing different countries in Europe. Almost all countries in Europe, let's say. The Adult Immunization Board was established with the aim of contributing to the reduction of mortality and morbidity from vaccine-preventable infections and diseases in European adults. What we want to do is to provide evidence-based guidance on fundamental technical and strategic issues of adult immunization. And we want also to monitor the progress of adult immunization programs at the European and national and subnational level. What is the way of working? We organize 2 meetings per year. One is a technical meeting, which means that we focus on a specific topic, a technical aspect on adult immunization with subject matter experts. And the other is a country meeting. We go into a country or in a group of countries, and we discuss country-specific aspects of adult immunization together with local experts, but we exchange experience also with the advisors so that we can learn from each other. And we want to create a platform also where people of the country where we have the meeting involved in adult immunization can discuss, can meet. First of all, sometimes they do not know each other, some of them, and can start future initiatives. Our meetings are on invitation only to keep the group small and to keep the discussion lively and very interactive. The focus audience are policymakers, researchers, public health experts, and healthcare providers. How we organize the meetings? We discussed with the advisors the possible topics and what we want to obtain through that meeting. We perform a literature web review, and we have decided the topic, and we draft an agenda inviting the top experts on a topic. Of course, the agenda, when it's decided by the secretariat, it goes to the 24 advisors for suggestions and clearance, and then we start to invite our speakers. We had until now 3 meetings. The first meeting was in November 2022 in Antwerp. It was the kickoff meeting where we made a sort of brainstorming. We invited people who could be subsequently invited to be advisors. And we asked ourselves what we want to do, what are our aims, and what we wanted to deal with in our meetings. Then we had the first technical meeting in Antwerp in April 2023, where we went into depth on the first topic, which is a very important one, assessing the health burden of vaccine-preventable infections in European adults, challenges and opportunities. And as you can see, what we want to do is also to publish our meeting outcomes in international journals to give visibility to our objectives and to our acquisitions. And here you can see the first two papers, one on aerosurveillance, on the health burden of vaccine-preventable diseases, and another one on vaccine, where we explain what the Adult Immunization Board is. Here you can see a never-ending list of potential topics that we have to cover, and so we have probably fuel or food for 20 years of meetings, but these are the topics that we decided to list and to go through in our technical meetings for the future activities of the Adult Immunization Board. And you can see that we go from organizational issues, communication issues, specific vaccine implementation, and so on. And we also are performing a list. We are trying to provide to experts a list of all vaccines which are used in Europe in the over 18-year-old population, because this is a list which is not available in any website, also institutional, and we want to give this tool. IADE is working hard to provide this tool to all the experts in Europe. Again, here you can see that we have a website, and we invite you to visit it. It's www.adultimmunizationboard.org. We have LinkedIn, video, publications, and so you can access very freely all the materials that we are providing and producing. So I hope this can be of interest. We hope really to have an impact in the future on mainly on the implementation of adult immunization, because we know that there are a lot of recommendations, a lot of documents saying that we have to provide a better possibility of being vaccinated to the adult population, but in reality, the coverages are really still very, very low for many adult vaccines. So what we want to do is to implement and to provide to the policymakers an explanation why they should invest more in the future in the adult and the elderly immunization. Thank you for your attention.
Thank you so much, Professor Paolo. We will now have a moment to answer to some of the questions that meanwhile were posted on either our social media and also on the comment section for this webinar. Nevertheless, I will urge people who are watching us through social media to also present their questions through here. So going on to the first question that we have, it's from Ivana. And Ivana asks us if vaccination recommendations for people suffering from chronic immune diseases are already available, and if we can expect positive and negative non-specific effects from some of those vaccines. Christine, can you answer this? Because I think it's addressed to you.
I wish I could answer it. I think it's a super interesting question because clearly the findings on BCG suggest that there might be something to gain in terms of using BCG as a vaccine to reduce the burden of autoimmune diseases in adulthood. I can point to studies showing that BCG given to patients diagnosed with multiple sclerosis, actually coming out of Italy, these studies show that BCG vaccine can reduce the risk of subsequent MS attacks, and also studies from the US suggesting that BCG used to patients with type 1 diabetes can, over a period of years, it takes some years for the impact to really manifest itself for reasons we still need to understand better, but that people with type 1 diabetes get more stable HbA1c blood sugar, long-term blood sugars, if they get BCG without having even the risk of suffering from more hypoglycemic events. So there is really intriguing research going on as we speak into the use of BCG vaccine as a treatment, potential treatment in autoimmune diseases. But basically, I think the non-specific effects of any vaccine given in adulthood need to be taken into consideration.
Okay, thank you so much. So we also have here an interesting question for pertaining to Portugal, where the national immunization plan recommends BCG only to some risk groups. And Inês wants to know, Inês, that it's not me, it's Inês Subtil, wants to know if what are your thoughts on this recommendation?
We have done studies in Denmark, or one big randomized trial in Denmark with more than 4,000 children being enrolled and randomized to BCG or no BCG. Overall, we saw no effect on the risk of infectious diseases up to 15 months of age. We saw a 10% reduction, which is very modest, but still was statistically significant and not trivial in terms of absolute numbers in the risk of developing eczema in the same period. So there might be some potential benefits of using BCG at birth. And what was interesting from the perspective of Portugal was that in the Danish study, we saw that there was actually also a very beneficial effect on the risk of infant infectious diseases if the mother had received BCG. And that corroborates a lot of findings we are now accumulating, where we see that if the mother is primed with the same antigen, it amplifies the benefits of the same vaccine in the baby. So potentially in Portugal, where you only stopped using BCG recently, there might be an added value of using BCG to neonates. But I would really love if it was possible, and if somebody from Portugal that has this possibility are listening in right now, I think it would be wonderful to do a randomized trial like the Danish one in Portugal. So take normal Portuguese babies who wouldn't currently receive BCG vaccine, but whose mothers received it as part of the Portuguese program, and randomize them to receive BCG at birth as they used to, or not to receive it as is current policy, and then compare overall health outcomes for instance, the first year or 2 years. That I think is doable, and I hope somebody will catch that ball and run with it.
Thank you, Christine. Now we have a series of questions addressing the issue of vaccine hesitancy. So I will read some of them, and then we'll give the floor to whoever feels comfortable in answering it. So Antonio Oliveira says that he thinks that one of the big issues in this field, at least in the Western world, is the increasingly worrying low confidence of society in the safety and effectiveness of vaccines, how we can handle that. Then Francisca Polido Valente asks if we could provide insights into evolving landscape of vaccine hesitancy, including any observed shifts in patterns or attitudes over time, particularly considering specific vaccines. Then also Francisco says, is there any compilation of how different countries deal with the balance between parents, caregivers, autonomy in deciding over their children immunization and the right of children to receive the vaccines? Yeah, for now, I will leave these three comments.
I can start, then Christine maybe can complete. So if we had the reply to the problem of vaccine hesitancy, we would be very happy. But it's a very complicated issue, and sometimes a very country-specific issue in some cases. The problem today is that people are worried. They do not remind what the vaccines have done in the history when a lot of people died of vaccine-preventable diseases. The problem is, first of all, I think a problem of education. I think we need to educate, first of all, healthcare workers, because it's proven that when the general practitioner or the specialist advises that a vaccine is important for your health, and I'm speaking particularly of the adult immunization, usually those who are hesitant are convinced. So we have to realize that the real anti-vax movement is a question of very few people. In Italy, we calculated a couple of years ago that the real anti-vax, which cannot be convinced by any way, are less than 1% of the population, but they are very noisy, and they make a lot of initiatives to convince the hesitant population, which is around 15%. So the problem is that we need to educate the population, and I think that we should start speaking of vaccines even in schools to make children understand the importance of this incredible tool. But we also need to educate doctors and nurses, because if we look at the coverage with influenza vaccine every year of nurses and doctors, I speak of my country, but I know that many other countries the situation is the same. We have 20% healthcare workers who get the yearly vaccination against flu. And this is an extremely bad example. I think we need to educate our colleagues. So we study a lot about drugs, about therapy. We study much less about vaccines and immunology. So I think there is need of a better education in our medical faculties and nursing faculties. And then we also have a problem of confidence in health authorities, but in general, confidence in authorities. So we need to restore confidence and make people understand that we have an incredible tool in our hands, and you have to be confident that science is giving you a reply. But I understand that in a world full of interactions on the social media, we have no categorization of the information. So the scientific-based information is as worth as the information which has no scientific basis in the social media. So we have, of course, a problem, and we need to learn how to communicate also on social media. I would stop here, and then so, Christine, if you want to complete.
I very much agree with you that the real anti-vaxxers is a very small, noisy but very small group, and all the efforts trying to discuss with them, I feel, are sometimes wasted. So there we are completely online. I think the best argument for increasing vaccination coverage is really to provide the data that shows that taking the vaccine is associated with overall health benefits. And if we can provide that data, it's my impression or my understanding, my experience that people will take a vaccine. Everybody wants to do what's best for them. So if you have very good documentation that a vaccine from a randomized trial showing that vaccinated do better in terms of overall health outcomes than unvaccinated, then it's very few people who wouldn't take the vaccine. So I think for me, the best way forward is that we do a better job in documenting also post-marketing, because I mean, this is something which in my view is best done independently from the industry, that we document well post-marketing that a vaccine comes with very strong benefits, then most people would take it. So my way forward can be said very briefly. The best tool against vaccine hesitancy is to provide data that proves effects on overall health, and also to be transparent when there are negative effects of vaccines, because that latter lack of transparency from authorities, in my view, has been misunderstood in a misinterpretation of how people would respond if authorities also sometimes were transparent about less positive effects, because the way that authorities right now communicate about vaccines seem to be that if we just continue to say vaccines are safe and effective, then everybody will eventually take them. No, they won't take them just the same way as if you is an airline company who says that our planes never fall down, then you wouldn't fly with them. You want authorities to signalize that they are paying due diligence to any safety signal, and they don't do that by just repeating and reiterating that vaccines are safe and effective. They do that by really picking up every time there is a danger signal or safety signal in relation to a vaccine and communicating transparently about it. So data and transparency, that was the two words I wanted to say with this, anyway, rather long answer.
Great, thank you so much. So moving on to the next question. I don't know if any of you feels comfortable in addressing it, but Duarte here asks if taking into consideration the invasion of Aedes mosquitoes, if we should consider routine vaccination against yellow fever here in Europe.
Yeah, I wouldn't put yellow fever as the first one, because I would say that before thinking of yellow fever, we should think of dengue fever and chikungunya, which are in reality in Europe. We have had several local transmission of these two diseases, and we have two vaccines that are coming into the market for chikungunya, and we already have a vaccine for dengue. Of course, we cannot think of giving this vaccine to the whole population, or until now, the use of this vaccine is mainly for travelers, but also for local situations where it was shown that there was a local transmission by these Aedes or Culex mosquitoes. But yellow fever, I think yellow fever until now is a problem of tropical areas, but it might become a problem in the future also in Europe. But let's start with the ones that have already been shown to be present in our continent in some areas with local transmission. And we have already one vaccine, and we will have other two vaccines soon. So we have to decide also by consideration of the costs, the epidemiological data on which population we should use these new vaccines.
Okay, thank you. We have here one last question, and we will have to close it. I don't think it addresses really the issue of this webinar, but nevertheless, I will ask our participants, our speakers, if they feel comfortable to address it, and what is your opinion on the PABS system proposed by WHO Pandemic Treaty draft? Do you think it's viable? What could be the main obstacles for reaching an agreement in the next World Health Assembly?
Unfortunately, that's outside my area of expertise.
Yeah, so me neither. So I'm not so expert in this topic. So I would I would reply something which is not very sensible.
Okay, so thank you very much to our speakers. We would like to, before ending this session, remind the participants, those who are hearing us, that you can access the link to the quiz in the end of this webinar. And we suggest that you use a mobile to answer the questions. Once again, thank you so much to Professor Christine Stabel-Ben, also to Professor Paolo Bonanni for your excellent presentations and views on these issues of vaccines that remain extremely important from a public health perspective and not only from a development perspective. And I will now give the floor to our chair, Dr. Ricardo Mexia, to finalize this webinar. Thank you very much.
Thank you so much, Ines, for the moderation and for also keeping time. And also thank you to our wonderful speakers for bringing several issues that are not always commonplace when we talk about vaccines, but they need to be on the agenda and we need to address them, of course. So thank you so much for taking time to be with us. And I also invite you to take time to participate in the quiz if you'd like. So you can use the link that's on screen right now. And in a couple of minutes, I'll let the participants join. So we're still at 23 players. This is the quiz will have several questions on UFA, on the conference, also on the upcoming conference in Lisbon, and also about the city. So it will take no longer than 15 minutes for the quiz, and you're all welcome to also provide your answers. I'll just give a couple of more minutes so people can register for the quiz. So we're now at 30 players, and you can also interact within the platform for the quiz. In the meantime, some comments from your side that we're also sharing. So thank you for participating. We had 70 people watching the session, so it's a good turnout. And I also take the chance to invite you to follow the webpage of the European Public Health Conference, where you can also find information on the upcoming webinars. As I mentioned, our second webinar on health inequalities was postponed, but hopefully it will take place in April. So you're welcome to join. I'll just give one more minute. We're now at 32 players registered, and please do participate. The link is on screen, and you can also find it on the you can type it in your browser. We advise you to use mobile to participate, but feel free to use any of the tools that you want to use, either your PC. So I'll give one more minute, and then we'll start the quiz. Remember, the questions will show up on the link that you have here, so ahaslides.com/EPHC Lisbon, so European Public Health Conference Lisbon. And there's added points if you answer quickly. So the question will be read beforehand, and then you'll have 10 seconds to answer. But the faster you answer, the more points you'll be awarded. So last chance to participate. We're now at 40 players, so I'll give the start in a couple of minutes. Please use the same email you've used if you've participated in the first session. Please use the same email to register so that we can add up the points for each webinar. So we will have a bigger prize at the end for the people who have received more points throughout all the quizzes. Well, so I think it's now time. So we're going to start the quiz. People can still register once we start. They'll just eventually miss the first questions. So without further ado, let's start the quiz. So question number 1. Which cities have hosted the UFA EPH conference more than once? So 10 seconds to answer. So we have 10 correct answers. And indeed, it was Copenhagen, Paris, and Brussels. And this answer will change in November because Lisbon will have hosted also the conference twice. So Elizabeth is in front. She was the fastest one to answer. Gustavo second, and CQ on third place. So let's move on to the next question. So how many members founded UFA in 1992? Is it 5, 15, 20, or 34? Okay, let's see the answers. Yes, most people answered correctly. So it was 15 members back in 1992, that started UFA. So let's see if there's a change in the leaderboard. Yes, apparently Gustavo is now in front. He was second, Elizabeth is in third, and Hugo is now in the third position. So let's move on to the next question. Who started the European Journal of Public Health? So was it UFA, the Karlstad University, the Karolinska Institute, or Oxford University Press? So let's see the answers. Oh, in fact, there's only one correct answer. Most people said it was UFA, but it was in fact Karlstad University. So let's see who. Okay, Leah Evans was now with a big leap forward, almost at the first place, but Gustavo is still in front. Let's see what the next question brings to the podium. What is on the cover of the European Journal of Public Health? So now you can choose the image that is on the cover of the European Journal of Public Health. Okay, so now let's see the answers. Most people answered correctly. It's indeed the map of Europe. Let's see if there are changes in the first places. So Gustavo is making stronger leadership. So he's now 18 points in front of João Dionísio, and Hugo is in the third place. Let's see what the next question brings about. Who was not UFA president? Was it Vivian van Kasteren, Natasha Azopardi-Muscat, Dineke Ziegers-Paget, or Alena Petrakova? Let's see the answers. Oh, it's neck and neck, but indeed, Dineke was Director General of UFA for a long time, but she was not indeed president. So 9 correct answers. Let's see the impact on the... So the ones in front did not give correct answers. So Francisco is now given a leap forward. So he's in second place, but Gustavo is still holding the leadership by 1 point. Let's see what comes up next. When did the first European Public Health Week take place? Was it 2009, 2020, 21, or 22? Okay. Yes, indeed. 28 people answered it was in 2019. So let's see who was the fastest to do so. And now, apparently, Francisco is in front, Hugo in second, and Emar in third place. Let's see what the next question brings. So we're halfway through the questionnaire. What is the name of UFA's Young Professionals Network? Is it Sons of UFA, Youngsters at UFA, UFA Next, or Mighty UFA? Let's see the answers. Yes, UFA Next is the name of the Young Professionals Network. So let's see how many answered correctly. And so now Francisco is in front, João in second, and Hugo in third. Filipe is trailing by only 6 points on fourth place. What is the sequence of the AAA strategy? Is it advocacy, action, analysis? They're all as important. Analysis, advocacy, and action, or action, analysis, and advocacy? Let's see the answers. Yeah, analysis, advocacy, and action, and most people answered correctly. Let's see how time-wise things unfolded. So João is now in first, Filipe in second, and Hugo is still holding in third position. Let's see. Next question. What is the correct name for the UFA section SSWH? Section of Security, Work and Health, Section of Social Services, Work and Health, Section of Social Security, Work and Health, or Section of Security, Workforce and Health? This was a difficult one, but still, most people answered correctly. So 10 people answered section of Social Security, Work, and Health. Let's see the podium. So now Filipa is in first, João is in second, and Elder in third. Elizabeth is in the fourth position. Which section is known to work on food marketing to children? Child and adolescent public health, food and nutrition, law and public health, or health technology assessment? Let's see the answer. Oh, most people answered food and nutrition, but in fact, it's law and public health, or at least that's the question. So let's see the answers. So now Hugo is moving forward, but Filipa and João are still holding first and second place. Next question. Lisbon is known for its vibrant street art scene. Which Portuguese street artist gained international recognition for his distinctive works, often featuring large-scale murals and the use of explosives as part of his artistic process? Vils, Bordal II, aka Corleone, or Ed Fuel? Vils was the correct answer, and most people did answer correctly. Let's see if it affects the leaderboard. So there's a change in second and third place, and Emmer is moving up. Let's see the last two questions. The promotional pin for EPHC Lisbon 2024 has an analogy to, and this is the image of the pin, Seven Hills of Lisbon and Ocean Waves, Mountains of Portugal, Ocean Waves and Alentejo Plains, or the flag of Portugal and mountains? It's the Seven Hills of Lisbon and Ocean Waves. So 15 people answered correctly. Let's see if it affects the leaderboard. Rafael is answering the 3 questions correctly, and Filipa is reinforcing her leadership. She's now almost 100 points ahead of the second one. So we'll see if the last question shifts something in the questionnaire. And this is the last one. How many entities organize the EPHC plenary session program? Is it 5, 9, 12, or 7? And the answer is 9. So 8 people answered correctly. Let's see if there are changes in the leaderboard. So no, Filipa also answered correctly. She has the longest streak record, so 4 consecutive questions. So congratulations to Filipa. She has won one dinner and dance entry for the conference in November. Congratulations, Filipa, for winning. And she has also gained 821 points, which will be added to the tally that we're keeping for all the participants. So we'll be looking forward to adding those up so that people can win free registrations to the conference in November. So we also want to award those that were here, but in fact did not have the first position in the prizes. So we're going to draft a free entrance to the gala dinner in Lisbon. So we're just going to spin the wheel and see who wins the free entrance to the dinner and dance. So here we go. And the winner is Elizabeth. So congratulations, Elizabeth, for winning also an entrance to the dinner and dance in November at Stufa Fria in Lisbon. And last, I would like to ask you for you to describe this webinar. So in a few words, can you please describe the webinar that we've just witnessed on the vaccines? I think it was a very challenging webinar. We've had a lot of disruptive comments and things that we need to discuss furthermore concerning vaccines. So please describe the webinar that we've just witnessed. So great, engaging, interesting, refreshing, enlightening, prevention, vaccines. So these are the words that are more commonly being used. Interesting seems to stand out. And there's also an interessante, which is interesting in Portuguese over there. So it would add to that one. So thank you so much for participating. It was very interesting to have this webinar. Stay connected with our webinars. We'll soon announce both the March webinar as well as the April one, and we'll be looking forward to have you on the session. In the meantime, do look up the conference page for November and save the date to participate between the 12th and the 15th of November here in Lisbon. So thank you so much, everyone, and see you soon on the next webinar. Thank you.